Now we have come to the last session of today. The session is on the inpatient rehabilitation facilities in the government and the corporate sector in West Bengal and in India, and the scope and limitations. For this session, I'd like to invite on stage the moderator for this session, Dr. Koustubh Chakraborty, consultant physiatrist, Peerless Hospital. I'd like to invite the panelists for this session, Professor Dr. Swapan Mishra, head of the Department of PMR, Calcutta National Medical College and Hospital, Dr. Madhusree Sengupta, consultant physiatrist, R. Tagore Institute of Cardiac Sciences, and Dr. Gaurav Thokral, internal medicine specialist, CEO and founder of HCAH.
Good evening. So this is now the last session, and the philosophy behind this session was that we were targeting through this program to reach out to specialties other than PMR, to reach out to the general practitioners, MBBS doctors, as well as our colleagues in different specialties. And this session would be to apprise them of what are the facilities available for indoor rehab. We know OPD rehab, we know that there are different therapy sessions, some interventions have already been discussed. But in the government sector, there are many inpatient facilities. In the corporate sector, which shall be represented by Dr. Madhusree Sengupta, there are inpatient facilities offering some different services, and centers such as Healthcare at Home HCH are standalone rehab centers, inpatient rehab facilities which have come up, that will be represented by Dr. Saswato Majumdar. So they offer a few facilities, so we shall discuss their advantages and disadvantages. Now, starting with Dr. Swapan Mishra, so what are the type of patients you'd like to admit in your inpatient facility in the government sector, that is Calcutta National Medical College?
Basically, in Calcutta National Medical College, we don't have indoor earlier. It was just started. We don't have good number of junior residents and all. We nowadays trying to admit those patients, those do not have any acute issues, mostly who are not able to attend daycare rehab services for their distance. So they get admitted, taken a session for a couple of days, and then get discharged. So that facility mostly we are providing. And few other departmental referrals may also sometime we try to admit, but mostly these two, those who are not able to attend OPD services regularly due to distance, and we will try to increase further different types of things.
And I'll ask the same question to Dr. Madhusree Sengupta. In your corporate setup at NHRTX, so what are the patients you usually want to or you usually admit in the inpatient ward?
So in the inpatient ward, there are two ways by which patients come. One is as a transfer from other units, or it is from the OPD. So those which are transferred from the other units, they are primarily neurological patients. Mostly we get post-stroke. Some are post-craniotomy or spinal cord injury patients, but primarily post-stroke. And the second group, those which we are admitting from the OPD, they are a mix of both neurological as well as pain patients for pain interventions.
Okay, thank you. And Dr. Saswato, you run a standalone rehab center, so that is, there are no other consultants or no other indoor facilities maybe for cardiac, neurology, orthopedic beds. It's pure PMNR beds. So what are the patients that you generally admit?
So HCH is the first of its kind single specialty PMNR hospital. So we get patients by two basic methods. One who come to us by word of mouth or by digital way, where they search for us online, and the other ones are by doctor referrals. So basically what we do is that we provide an out of hospital care where we are providing from acute to subacute to chronic care on OPD IPD basis, but at a lower cost from a multi-speciality hospital maybe. That is our forte.
Okay, so if this facility was not there, maybe after acute care the patient would go home and receive some home-based rehab. So I'd like to ask Dr. Swapan Mishra, what extra facilities does an eligible patient receive in the inpatient rehab department in the government sector?
See, during my earlier panel discussion, so I said that type of rehab may be in indoor rehab facility, IRF, or maybe community or home care. So that depends on the patient's condition. If patient needs some supervision of clinician or other, then indoor rehab is required. Otherwise, home-based rehab is the best because the ambience is comfortable for the patient for recovery, because psychological support and all what they will be getting at their home will not be available at in a hospital or this thing. So cost also an issue important. So if the patient do not need any supervisory care, then we can try for home care or this community based rehab, whatever may be.
Okay, Dr. Madhusree, you want to add to that what extra facilities patients might receive as inpatient care vis-a-vis home care, domiciliary care?
Yes, I differ slightly from Professor Mishra, because primarily the IPD based patients that we keep are either stroke or spinal cord injury. Let's say take stroke, where multiple therapies are applied. You know, apart from the physiatrist's input, there is the physiotherapy, occupational therapy, SLP, might be psychology. So many things in an isolated way, it's very difficult at a home setup. You might argue that are they really all that important? Well, they contribute. They definitely do contribute. So, I always feel and I would suggest inpatient-based rehabilitation for these group of patients. One, who need multiple kind of disciplinary approach. Second, who need to be monitored. Third, also we need to look into the social structure a bit. Not all families are capable of handling a bedridden patient in a big way. So if we can bring the patient to a certain level where the patient is off tubes or ambulatory to a certain extent, in the long run it brings down the cost and the caregiver burden. So from these aspects, I would prefer IPD based rehab over home care, or use this as an interim period between intensive care and home care.
Okay, and asking the same question to Dr. Saswato. So in your center, what are the extra facilities you foresee for a patient admitted here vis-a-vis the same patient receiving maybe one supervised therapy by a therapist at home and family member input?
So I absolutely agree with my previous speakers. Only one thing I would like to add here, that I tend to get a lot of critical patients because we also provide a step down ICU care at our center. So those patients will not qualify for home care, but those patients that they qualify for home care after their treatment in IRF, well, they do not require any advanced equipment that cannot be provided at home. We try to provide home care to those patients, and our target is to get the maximum benefit to them at the lowest cost. So that can be achieved at home care much better than a stay at a hospital maybe.
Okay, and since you have mentioned that you provide a step down services, if any of our esteemed audience members in their private practice or in their course of their handling the patients, they feel that this particular patient is in need for indoor services and maybe in a step down unit, maybe in a cold ward, so how do they send it to you? So starting from you, Dr. Saswato.
Absolutely, everybody is welcome, and as I said, that PMNR only hospital, that is our care pattern. So we have all the other disciplines empaneled with us. So whenever a patient is admitted, if they require help of a, say, a neurologist or a neurosurgeon, we always get their consultations done. It's not like only the PMNR is treating the patient. As well as that, if anybody wishes to admit to our care, we also provide the option of joint attending, where the patient is admitted under both of us. So that is another option, so that the patient also feels secure in a new environment where they're still under control of the doctor they were primarily seeing. So that part is very important. So anybody can reach out to us and can come to visit our center and see how we are doing. And if you're interested, please join us.
Okay, and Dr. Madhusree Sengupta.
Same question?
Same question, yeah.
Yes, reaching us is the normal way. Like in the hospital, they can come through the, use the internet facilities, they can come for inpatient OPD, in-person OPD visit. There is of course the contact numbers as well. There is a liaison with doctors of other specialty who get in touch with us sometimes personally, and social media, of course, it helps these days. So, and the rest is transfer directly from one unit to the other.
Okay, and for Dr. Swapan Mishra, I know there's a lot of burden on government hospital beds. So how easy it is to get a bed in your inpatient facility for an eligible patient?
No, it's not that. Actually, our OPD, IPD bed is available because we are restricted our admissions due to inadequate human resource mostly. So accordingly, we can admit those who require, and it is available. But the one point I want to add about earlier question. First of all, home care not necessarily mean care by the family members. You can set up home care at a highest level with using tele-rehab facilities, with using other rehab professionals other than doctors in the remote area also. So home care not necessarily mean that simple by the family members. So you can control a home care service even in the remotest area with regular monitoring and all. So home care is the point you was asked in the earlier question. No. Indoor rehab is required where clinical monitoring, supervisory monitoring, regular required about the patient's condition, clinical condition. As everybody was accepting the same thing, that depending on condition, home care or this, but home care not necessarily by the home family members only. There may be physiotherapists, there may be occupational therapists. They can attend there at home. You are monitoring from here, guiding, recording all data. Also, you are sitting here, you can monitor it using all the modern IT gadgets. So that's the point I want to clarify about my earlier
Okay,
answer.
and every patient is different, the degree of affection, their age is different, but say for a case of stroke patient who after hemodynamic stability has been transferred to your unit, so how long, I'll start with Dr. Swapan Mishra, so how long do you want to keep that patient in your inpatient care before discharging to the community, ideally?
Same thing, if it is clinically stable, if it is able to basic ADL can perform by himself or herself or with minimal assistance, then he can, and if accessibility issue is not much there in his home or otherwise, then we can discharge, that can be done, no issue.
Okay, and you want to add anything, that what is the median time a patient of stroke
Yes.
maybe stays?
I think this question, I always ask the family, what is your expectation? At what stage do you want to take the patient back? Because not every family structure is the same. So if the family structure is such that I know once I remove the tubes and send the patient home, the patient will be well taken care of, I'm okay with that. For some patient, it might be that unless the patient is ambulatory, it is difficult for us to take care. And ideally, if you're asking for an ideal scenario, then it should be till the patient is able to go to the toilet on his or her own. That is the ideal scenario. But practically, since in the corporate sector money is involved, and not everybody is covered by insurance, so I give the family that goal, and I always make those goals in terms of weeks. So let's have the goal setting for this week. If we reach these goals, we make the goal setting for the next week. So that's the way we approach it.
Okay, and what about you, Dr. Saswato?
For us, the method is exactly the same, and our point of termination is when the patient can walk to the bathroom on their own. And of course, as she said, that a lot of patients, they may require further care. Some may choose to stay back and get to full mobility, to the full level of independence. If they seek that, then we try to provide that. But usually, up to the level where the patient can go to the washroom on their own, can use the washroom on their own.
Okay, and you have mentioned, Dr. Madhusree Sengupta has mentioned about the cost, so I'll start with Dr. Saswato. So average, on an average in a stable stroke patient, what is the average daily cost who is receiving maybe 6 sessions of therapy, various therapies per day?
So it depends on the level of care basically. If the patient is all tubes, then it's different, and without tubes it's different. But somewhere in the median lines of 7 to 10,000 is the sweet spot where the most of the patients will be able to afford and they will get the maximum benefit.
Okay. What about you, Dr. Madhusree Sengupta?
Firstly, it depends on the ward. When it's an ITU, when it's an HDU and or a tracheostomy tube, the cost goes in a much different way. So if I look at a general bed, assuming there are 2 sessions of physio, 2 sessions of occupational therapy, 1 session of SLP and the doctor's visit, it would come somewhere between 10 to 15K per day. And again, assuming no big investigations are being done. So it would be somewhat like this.
Okay. And for Dr. Swapan Mishra, most of the treatment in government hospitals are free. But do the patients need to bear the cost of consumables like maybe a tracheostomy suction catheter, DVT stockings, a vacuum assisted closure, or maybe some advanced dressing material like alginates for their pressure injury, some nutritional supplements? So do the patients have to buy them?
Obviously, they have to buy it. But there is Saswato card. Sometime by this way also we can get some free services, free equipments and all.
Thank you so much. So there is some sort of social support for those who are getting treatment in government sector. Okay. So in the government sector, is there any scope for daycare facility, daycare treatment?
What type of?
Suppose the patient comes in the morning, undergoes 3 or 4 sessions in that day and gets discharged in the evening, or maybe there is some medicine has to be administered, that is administered followed by therapy.
No,
So
what
some-
we do in daycare is that is procedures, interventions, small, that we are doing.
Okay.
USG guided intervention and all are free of cost. And daycare means OPD therapeutic services. That is also regularly we are doing free of cost.
Okay.
Coming and when people are unable to come daily, then we admit what I said earlier. That is the point. So they stayed in for 7, 10 days, 20 days, get the therapy done, improved, then we discharge.
Okay.
But
And
they are not acute.
so, Dr. Madhusree Sengupta, do you do daycare facilities as opposed to somebody attending the department for OPD say based sessions, or maybe just a procedure? A daycare can mean that the son or the daughter takes their father to your center in the morning, they undergo 6 sessions of therapy, they receive food from the hospital itself, maybe their toileting care is taken care of by the nurses, which is not so in case of OPD, because then a family member has to be present and give food and do the other things, and in the evening they can take the father back. So does any such thing exist?
There are certain packages that we have created with respect to interventions. For example, botulinum toxin. So those have daycare packages where there is botulinum toxin, doctor's visit, rehab sessions, everything. Or for pain interventions as well, therapy, pain intervention, the whole daycare package is there. For other, like you're saying, let's say for a stroke patient on a daily basis, no, we don't. But that's primarily because I'm the only physiatrist there and I will have to write a discharge summary every single day. So once I can figure out a solution for that, maybe yes, we'll have that.
Okay, and what about you, Dr. Majumdar?
So with us, we have multiple different packages, and we do daycare, particularly for blood transfusions or maybe injectable biologicals, those sort of things. We do provide daycare packages. Other than that, for therapy only, we also have daycare packages. So those patients who come from a very good distance, they would need a place to rest at least. So for that, we provide hourly basis, even daycare packages. We do that.
Okay, thank you so much. And the last set of questions. For patients who are discharged from your inpatient facility, do you have any outreach program to maintain the continuity of care? So I'll start with Dr. Majumdar.
Yes, absolutely. So our process is that we start with IPD, then move to OPD, and ultimately we provide home care. And at home, we continue the care point of care up to 2 months maybe in most of the cases. And even after that, we have outreach programs. So our team keeps on reaching out to the family members and to the patient to assess their level of functionality. We have multiple different studies going on right now under HCH, and some of them are with the the different aims like AIMS Jodhpur and AIMS Gorakhpur. So one of those studies, we are actually measuring a long-term follow-up of those patients basically.
Okay, it's so nice to know. What about you, Dr. Madhusree?
If they are within the city itself, yes, outreach facilities are available. If they are not inside the city, we try to do the liaison with ex-interns of the hospital. But if that is also not possible, then the therapy has to be taken care of on their own. But we are happy to teach the family members and give guidance. We also coordinate with the therapist in different cities, and online consultation we do. But no, across the state we don't have outreach services.
Okay, thank you so much. And I know this shall be very challenging, having an outreach session. So I won't ask you that, but instead I'll ask you a very important question to round off this panel discussion. So how does an eligible patient, maybe of stroke, maybe of spinal cord injury, apply for and receive a disability certificate in our state? It's for Dr. Swapan Mishra.
No, this is not in our state now. This currently it is under Government of India single portal, UDID portal, you know. Earlier it was state-wise issue, now it is all over India single portal. Anybody can apply for disability certification, assessment, etc. from anywhere in India, and they can choose any hospital amongst the list is there. Commonly they prefer to choose a hospital where they have get treated or otherwise. Suppose a person of Jharkhand is treated at Kolkata, he may get certificate from here. It was earlier Aadhaar based, address dependent, zone wise, etc. Now it is all are off. So now we are doing UDID certification for any patients anywhere they are coming, and there are 20 types of disability listed in the UDID portal, so they have to choose for the application. There are a couple of steps to put up, and they will generate enrollment details. So accordingly they will get enrollment certificate. This enrollment, then they will get the hospital, they will visit the hospital, step 2, step 3, they will get an assessment date. On that day only patient will come, he will be assessed by the, according to the, there are guidelines for who the specialist for what type of disability will assess. So according to assessment, there will be a review medical board who will give the percentage and type of disability. So then the thing will be uploaded and they will download the certificate from online. They don't have to come to the hospital to get the certificate. Earlier it was hard copy. And there will be an UDID card which will be posted by speed post from the hospital to the residential address. There are 3 types of card. Below 40% means below the benchmark disability, they will get white card. 40 to 80% they will get probably blue card, and then beyond 80% they will get orange or something. 3 types of color. So below 40% also they will get a UDID card.
Thank you so much. Thank you so much, Dr. Swapan Mishra. So just to summarize, I want to give this take-home message to the audience that inpatient rehab facility is available in our city in various strata. In the government sector, it's available in many of the government hospitals. In the corporate hospitals also they are available, and as well as there are many standalone centers like HCH, Healthcare at Home. So they are also coming up in a big way to provide inpatient services for the patients, needy patients in rehab. The cost will vary as per the setup, but as you have got a fair idea of what shall be the cost. The benefits are, of course, supervised therapy session. They'll get a lot of different types of therapy, maybe physical therapy, occupational therapy, speech therapy, and some of the therapies they'll get it twice a day, which is not possible in a home care setup. There are some daycare packages which are available, and also when you come across any patient who has a condition that might have a long-term disability, so kindly do visit the UDID portal so that you can really help your patients get a disability card for which they are eligible for some government benefits, and if they qualify for that, so they should receive the benefits. Thank you so much, and with this I thank the panelists and end this session. May I call upon Dr. Dibyendu Das to kindly deliver the vote of thanks at the end? Yeah. Okay. Oh, okay. Yeah. What about you? Okay, so I'll do it. First of all, I'd like to thank the West Bengal Medical Council for approving of this CME program and accrediting 5 hours, and the process was so smoothly done that we were really surprised ourselves. Second, I'd like to thank our Honorable DME for coming and gracing the occasion, the inauguration session, as well as participating in a very important panel discussion, which is quite important for our specialty. I'd also like to thank the Principal of RG Medical College, Dr. Madhusree Sengupta, for gracing this occasion and also lighting the inaugural lamp. My thanks goes out to the organizing president, Dr. S.P. Sinha, and our senior most patron, Dr. Manmohan Bishwas, for being with us all through this journey of organizing and finally seeing this unique type of CME, which is a multidisciplinary rehab CME, come to fruition. My thanks to Dr. Swapan Mishra, who has been instrumental. He has been the pivot for all the work that has been done. It's through his contacts, his connections, the press, through people in various faculties of teaching hospitals as well as non-teaching specialities that we have been able to get so many faculties not belonging to PMR into our program, and they have gladly agreed to come and also make this session as interesting as they were. Special thanks also go out to Dr. Tanmoy Noshkar, Dr. Shagnik Mukhopadhyay, who have been working, and our two house staffs. I've just recently got to know them, but they have been so instrumental in doing all the footwork, all the hard work, staying up till 2 a.m. at night to compile all the computer-based lists so that we could get all this program together. A special thanks to all the faculty members who have contributed their academic input and all the delegates who have heeded our call and registered for the conference. And finally, I'd also like to thank our sponsors for making this program possible. Thank you so much and have a good day.
Okay, one point I want to just mention that we have not given thanks to Koustubh because he is the instrumental in doing all academic things. And another point, that we have already confirmed for RehabCon 2026 in a more way, and hopefully we will do another RehabCon in a different format in this year also. That also almost confirmed. So this multi-speciality conference is very interesting for all of us, and we will continue years together and will in a better and bigger way. Thank you.